So dietary assessment is obviously very fundamental and foundational to much of what we do in nutrition research. I took a little look on Google Scholar and found some articles that were relevant to the Norwegian context and that were drawing upon dietary intake data. And I also tried to find some images to go along with these. So when I looked in North America, this is what we think of as a popular snack food here in Norway, and I found out this morning that that is in fact true, so I'm going to have to search this out and try it out. So we know from the research that we've done using dietary data that dietary risk factors are among the leading contributors to mortality and morbidity globally. And so this really has led to an unprecedented level of attention to policies and programs to try to support healthy eating patterns. And so back in Canada, we have for the first time ever a federal healthy eating strategy. Internationally, we have the World Health Organization, and up here, the World Cancer Research Foundation with their Nourishing Framework, which recommends different levels and types of interventions in order to try to overcome barriers to healthy eating. And then I saw here in Norway that there's the Partnership for a Healthier Diet, as well as the Salt and Salt Partnership, or Salt Initiatives and Salt Partnership. So in order for us to know what to target, as well as to look at whether our interventions are effective, we need to be able to track what people eat and drink. And so what we want to do really isn't that unreasonable. We want to be able to characterize dietary intake and eating patterns among populations, better understand the drivers or influences on those patterns, and then identify strategies to try to improve healthy eating or eating patterns across the life cycle. And so we're thinking about what kind of tools or measures will help us do that in the most policy relevant ways. Again, what we want to find out really isn't that ground shattering. We want to know what people are eating, how much they're eating, how often they're eating these different foods and drinks. We then want to link that information to databases like food composition and food group information so that we can translate this into levels of nutrients, food groups, other dietary components. And then we might also be interested in contextual factors like where you were during the eating occasion. Were you eating with others? Were you on your phone while you were eating, posting your lovely dinner at the hotel to Instagram, for example? So again, this doesn't seem that hard to get this information. So why is it? And this is partly because diet is so complex, and this complexity makes it hard to capture these kinds of elements in a simple way. And so we all know here in this room that diet is multidimensional. We eat and drink many different foods and beverages. We might also consume supplements. Each of these comes with its own nutrient profile and other dietary components as well, such as phytoestrogens or those kinds of things. And these dietary components might work in synergy, or they might work against each other to influence our disease risk. We also know that diet is dynamic. We eat and drink different things across the day, over days, across months, and across the year. And also diet varies in relation to the life cycle, and there might be critical periods of time during which our eating patterns are really important to our future health or disease risk. Against that backdrop of multidimensionality and dynamism, what we're usually interested in dietary assessment is usual intake. We want to know long-run habitual intake. And this is because we know that dietary recommendations are meant to be met over time. Our bodies can store nutrients, so we don't necessarily need to reach our targets each and every day. For epidemiology, understanding diet and health, we hypothesize that it's diet over the long term, not what we might have eaten for breakfast today, that's going to influence our disease risk. And for interventions, generally we want to change people's long-term eating patterns. This is not to say that acute exposures are never important, so things like contaminants, like mercury in fish or that kind of thing. But for most research, we want to know about usual intake. And so the question is this usual intake actually observable? So what we're often told is just use objective markers. Why don't you just use biomarkers or observe people? And those are really useful ways of collecting dietary data. We're going to hear more about biomarkers this morning. But they're not really feasible for much of the research that we're doing out in the field with free living or community dwelling populations. So for example, recovery biomarkers, which can be very useful for helping us to understand things like the measurement error in dietary assessment measures, They're only available for a couple dietary components. These include energy, protein, potassium, and maybe sodium. They're burdensome, they're high cost, so we can't use them for very long in large samples. And importantly for us, in terms of thinking about how we track and change eating patterns, biomarkers don't actually tell us what people are putting into their mouths. And that's what we want to know in order to design policies and programs. So this means that in the vast majority of our research, we are reliant on self-report tools. So when we think about self-report tools, we could put these into two different categories, short-term and long-term. So the short-term measures are providing us with a snapshot in time. These include our food recalls and our 24-hour recalls, as well as food records or diaries. That was the jet lag. I'll just blame that there. And then our long-term measures, we're aiming to capture usual intake directly. So things like food frequency questionnaires and screeners or brief instruments. So brief instruments can come in lots of different forms, but often they are frequency-based and trying to target certain aspects of the diet, like fiber or fat or sugary beverages or that kind of thing. So our short-term measures, they are useful in terms of providing us with rich data on the total diet. So all the foods and beverages that we consume. And this allows us to look broadly at patterns of intake, how intake of something might be high and intake of something else might be low, like whole grains and sugars, for example. Gives us flexibility for analysis in terms of looking at multiple dietary components, not just sugary beverages, but if you change sugary beverage intake, what happens to juice or water or whatever else you might be interested in. And because recalls and records aren't using predetermined food lists, they can be considered somewhat culturally neutral, and they facilitate comparability across studies. Even though with these measures we are focused on the short term, we usually are collecting and analyzing them in such a way to get us to usual intake, and I'll talk a little bit more about that later on. In contrast, the long-term measures, again, they might focus on specific components, or they might include enough foods and beverages to get us estimates of total diet. Because they are trying to get at usual intake over a long period of time, such as the past month or the past year, these can be really useful for understanding dietary components that we consume more regularly. So in Canada, that would be things like whole grains and fish. Not sure if fish would be episodically consumed here in Norway or not, but those are foods that we might miss if we use recalls and records and only collect a couple of days of data. Traditionally, these long-term measures have been more feasible, and that's why we've seen them used in much research, but that has started to change. So regardless of which measure we are using, all self-report data come with measurement error. And in diet and in nutrition epidemiology, we're very open and very transparent about our error, and that sometimes leads people to criticize us. We'll come back to that later. But error affects all kinds of measures. It's not exclusive to dietary intake data. But in order to use our data to the best of its capacity and to interpret it appropriately, we need to know what does this error look like and what does it mean for our results. So error can be either random or systematic. Random error error overall is the difference between the true value and the value that you've observed. So random error would mean that the differences between truth and observation could be in either direction from truth, which is actually great. In that case, we can get repeat measures and average out those variations. Systematic error, that's not the case. Our errors are always in a consistent direction. So if you think outside of diet of a weight scale that's not properly calibrated and it's weighing everyone in at 5 kilograms less than truth, that's systematic error. No matter how many measures you take, if you average them, you're never going to get to the right result. And so that's skewing or biasing our results. What are the sources of these types of error in dietary data? Well, the first one goes back to dynamism. So we know our intake varies. We mostly focus on day-to-day variation when we're thinking about short-term measures. If we're interested in usual intake, it's not that that variation is error. People aren't lying to us about what they ate that day necessarily, but it's just that one day is not giving us a good estimate of multiple days of intake. And so we consider that a source of error when we're interested in usual intake. Other types of error are from the interaction between individuals and the measures. And so this can include recall bias if we're asking people to tell us about what they ate in the past and they forget certain things, reactivity bias if we're asking them to track in real time and that causes them to change their behaviors, social desirability biases which might interact with body weight, for example. So as body mass index increases, people might be less likely to tell us about things that they perceive as less healthy. Cognitive challenges when we're talking about things like food frequency questionnaires, and you're asking people to tell me on average how many times you ate this certain class of foods and beverages over a long period of time, especially if it's something that varies seasonally, that can be really difficult. Lack of coverage of important sources, so a food frequency questionnaire that maybe omits important sources of the dietary component of interest in the target population, that will lead to omissions of that important source. And then also databases are important. We know that databases can have inaccurate or missing information that's going to contribute to reporting or add to the reporting error. Why do we make such a big deal about measurement error in this field? It can skew our results and lead us to erroneous conclusions. So this is an example from surveillance using short-term measures. So based on a single day of intake, 2 days that have been averaged, and then this is actual usual intake. And if we're interested in something like the proportion of individuals in our sample who are above or below a threshold, so this could be fruit and vegetable recommendations or sugary, free sugar cutoffs or that kind of thing, we have too much variation because of random error or that day-to-day variation, and so our inferences are going to be incorrect. When we think about diet and health relationships, here we have usual intake and observed intake in the red line, usual intake in blue. And what generally happens, this graph is limited to thinking about only random error. We generally have attenuation, and that means that the observed relationship between the dietary exposure and the disease outcome is biased towards the null. In other words, we're likely to miss an important relationship that actually exists. This is exacerbated by a loss of power that's caused by measurement error, and so this is why we end up having really huge and really expensive cohort studies to try to figure out what are these associations that actually exist. Again, this is limited to just random error. In the real world, all these different sources of error come together and can result in unpredictable effects on our findings, but generally what we do see is attenuation and power loss. Again, measurement error is not a new thing that we're just starting to think about in dietary data. This is Dr. George Beaton, who happens to be a Canadian. He's actually sort of my PhD grandfather because he was my PhD advisor's PhD advisor. And so he's been thinking about, or he's now passed away, but he was writing about these issues back in the 1970s and 80s. This is a paper from 1994 where he states that dietary intake cannot be estimated without error and probably never will be. The future lies in improved estimation and understanding of the error and development of analytical and statistical methods of coping with error, rather than improvements in dietary methodology per se. So I will say, George Beaton was this really intelligent man. He didn't necessarily know about the technological innovations that were coming and that we've seen in the last decade or so. But this was really important in terms of the analytical and statistical method advances that we've seen. So in order to have those analytical advances, we need to understand what the error actually looks like in data from different measures. And this comes about from validation studies that use unbiased reference measures. So this could be observation, but it also could be, again, going back to those objective recovery biomarkers that we have that provide us with markers of true intake for at least a handful of dietary components. And so back in the early 2000s, the OPEN study results were published. That was the first big biomarker study that actually kind of turned the field a little bit on its head by showing that food frequency data had more systematic error than 24-hour recall data did. And that's what led to some of the advances we've seen since. There have now been enough big validation studies that they were able to be pooled to look at how consistent the results are across different samples and using different versions of FFQs. So these are results from a pooling project that brought together 4 different studies. And what you can see here is for energy, yeah, the story is bad. We are not able to estimate energy intake using self-report tools. We know we have anthropometric measures, so that's okay. We don't necessarily need energy intake from self-report. You can see for the FFQs across studies, the extent of underestimation, and I call it here underestimation, not underreporting, because it's not that people are underreporting their energy, they're underreporting foods and drinks that is then resulting in us underestimating energy intake. But it can be up to 1/3 of energy. A little bit smaller for recalls depending on the population, but not great, right? But if you look at protein and potassium, it's a lot better. And this suggests that actually we can have confidence in thinking about other aspects of the diet, including things like fruits and vegetables. So if you look at the 24-hour recalls here, 5% difference between biomarkers and self-report for the recall, and 0 to 4% across different studies that were pooled for potassium. That's pretty good. In any other field, if you talked about being able to get within 5% of truth, you'd probably be pretty happy about that. And this here is using doubly labeled water for energy and 24-hour urine collections for these other nutrients. Sodium, not so great. We know sodium's a difficult one. This partly relates to variability across foods, so it's probably partly database issues, but sodium's one where we need more work done, and I'll come back to that a little bit later. So in terms of different measures, what these studies also allow us to do, or statisticians that we collaborate with, is to apply measurement error models and partition out the different types of error that affect our tools. So we actually can estimate the extent of random error and the extent of systematic error affecting our data. We can also look at the extent to which findings for diet and health would be likely to be attenuated or biased to the null using different tools. So what we know about 24-hour recalls from these pooled validation studies is that this is not to say that they don't contain any systematic error. They do, but they contain less systematic error than frequency questionnaires. They do, however, contain a lot of random error. And again, that comes from the fact that we're collecting a snapshot in time. And again, we're interested in usual intake, and so that variation across days is considered to be a source of error. As I mentioned earlier, we can deal with that. So if we were interested in a given individual's usual intake, we would have to capture many, many recalls, like maybe more than 300, depending on our dietary component. But at a group level, we can use statistical modeling and draw upon only a few repeat recalls. So random error actually is kind of dealt with. We don't need to worry too much about that when our interest is in usual intake. And in this case, we're kind of assuming that the recalls are unbiased, because that allows us to keep moving forward in the field. If we otherwise just throw up our hands and say we can't get to perfection, then we're sort of admitting defeat and deciding that we can't actually work to improve the diets of populations, because again, we need to be able to track our interventions in order to justify them, right? So we do make this assumption of unbiasedness, but we always have to keep in mind that there is measurement error and think about what it means for our findings. For food frequency questionnaires, again, these biomarker studies consistently show that frequency data contain more error, systematic error or bias than the recall data. If you think back to the sources of measurement error, this makes sense. For an FFQ, you're asking people to tell you about a long period of time. Again, you're asking them to do pretty difficult mental gymnastics in some cases to come up with some average of how often they had I should have looked up what a seasonal food in Norway is. For us in Ontario, it would be strawberries. So in some summer months, people would eat a lot of strawberries, but during the winter, we get like imported, not very good strawberries, and intake goes way down, right? So trying to think, okay, how many times did I eat strawberries in June compared to the rest of the year, and sort that out into a representative average for the year is really hard. And then also adding portion size into that. So there definitely is quite a bit of systematic error in frequency data, which really does limit their usefulness as a sole instrument on their own. That's not to say that they can't be useful in combination with other measures, again, going back to their capacity to give us data on less frequently consumed items, like again, fish would be in Canada. I haven't put screeners up here because screeners only collect information about particular dietary components. They can't really be compared to biomarkers because unless it was a protein screener, for example, but that really hasn't been done to any great extent. So what does this mean as far as matching tools or measures to a research question? I mean, in all cases, we want to use the best possible instrument or measure, and that's a measure that's unbiased. Again, we can deal with random error. We know how to do that, and so if we can collect data that are unbiased, that'll get us closer to where we want to go. We know that an unbiased instrument doesn't exist, and so we then recommend the use of the instrument with the least amount of bias. Again, assuming in some cases that recalls are unbiased. We also can take advantage of the strengths of different instruments, using them in combination, and design our studies in ways that allow us to try to correct to the extent that we can for measurement error. So what does this actually mean? If we think about examining diet and health relationships, most cohort studies to date have used food frequency questionnaires. That's because they've been inexpensive, self-administered. But what if we actually could collect 24-hour recalls in large cohort studies? Again, that would get us closer to getting to true usual intake, and then we could use food frequency questionnaire data to provide covariate information, again, particularly related to less regularly consumed items. I put in food records here as well, even though most of the biomarker studies to date have not included food records, but we assume that their error profile is likely to be similar to 24-hour recalls. So there have been a few papers that have tried to simulate what would happen if in cohort studies we collected multiple recalls over a year, so maybe 4 to 6 recalls, spread out by a couple of months each over a year, and then also collect a food frequency questionnaire and put those together, put that information together. And these studies or simulations do show that we get more precise estimates of intake, which is only going to help us in terms of getting closer to the true associations between diet and disease or health outcomes. A few questions that are still to be answered include whether participants will actually complete these multiple recalls. Some studies suggest that they will, but you will have people that will miss some, right? They're not available to complete the recall on the day that you ask them to. So maybe you ask them again, but they're traveling or whatever. There's going to be reasons that people won't be able to complete a tool during the time period that you want them to. So we have to make sure that our statistical techniques can account for missing data. We also don't know whether over multiple administrations of an instrument, if quality starts to go down. So people get bored with it, they've done this already, or on the flip side, whether there's a training effect, so they actually get better and more efficient at it. And I think the evidence for recalls is actually showing the latter, that people get more efficient and actually better at it. But this would depend on the age, the life cycle and age stage as well. So if you're talking about adolescents, for example, and you're trying to get them to complete multiple whatever kind of instrument, and it's not really a very interesting instrument for them, you're going to have boredom and maybe declining quality. So thinking about the interface is also important. We also don't know whether food records will perform similarly to recalls. So I mentioned most biomarker studies have not included records. We're now working with a data set that includes online recalls, records, and an FFQ and a screener, actually. So we're comparing all of those to biomarkers, and that will help to address some of these questions. But one important issue is whether a 4-day food record is equivalent to 4 recalls. Our 4 recalls we would want to be collected on non-consecutive days so that we can account for that day-to-day variation. 4 records in a row, you can end up having autocorrelation. Or like, for example, for me, staying at the lovely hotel, having a very similar breakfast probably from day to day, although my breakfast at home is the same every day too, so that didn't really matter. But you think about leftover effects, where you might eat last night's dinner for lunch today, that kind of thing. And so having 4 consecutive days doesn't give you as much information as 4 non-consecutive days will. So a few things to still figure out. But we have started to see cohorts moving towards this approach of collecting multiple recalls or records along with frequency questionnaires. In the US, they are starting a study of 1 million Americans where they're trying to capture these multiple recalls and food frequency questionnaires to try to provide really more data than has ever been available before on eating patterns. So if it's not possible to collect recalls or records in a large cohort, all is not lost. We still can correct or at least adjust for measurement error. So if in our cohort everyone's completing a food frequency questionnaire, that's our main instrument. If we at least do a calibration sub-study where we have some people provide biomarker data and or complete recalls, then we can use those biomarkers or those recalls to at least remove some of the error in our food frequency questionnaires. And just as an example, I'll just skip to this one first. This shows from the largest cohort in the US, the odds ratios between dietary fat intake and breast cancer risk when you correct for error using recall data and when you don't. So you can see in this case, both of these would be considered statistically significant, but this one's getting pretty close to 1, and you can see how we might be missing some important associations because we're not actually trying to mitigate this error. And so it has been suggested that diet-health relationships that are published in the literature that have not been corrected should be viewed with caution. We also need to use corrected a little bit carefully because if you're calibrating against a recall, again, the recall does have some error, so it's not fully correction, but it's at least some mitigation for that error. Another example comes from food environment research. So this is a review we did. One of my colleagues, she heard about this really cool study where it was a natural experiment where researchers were tracking the opening of a new supermarket, and they wanted to know whether that new supermarket opening would impact people's dietary patterns. And so they did quite a bit to characterize what was happening around the food environment, and then to measure food intake. What do you think they might have done? How many people think they did like a very thorough examination of dietary intake, as opposed to maybe asking one question? So they asked one question: how many fruits and vegetables did you consume? I think it was in the past 7 days. And it was otherwise like an excellent study, but my colleague was just like, why are you putting all these resources into your outcome, your exposure, but then your outcome is one question? And I don't know, those of you who work in dietary assessment, I don't know how many times I've been asked, okay, I have room for one question on my survey, or I have 2 minutes on my survey. What can I ask people about their dietary patterns? And my colleague, Amy Subar, says that it should be, do you eat? That's all you can get at with one question. But anyway, back to this. So that study, where they used a single item for their outcome, that prompted us to take a deeper look at the food environment research. At the time, there was an explosion in this area, but it was clear that the results of these studies were very contradictory in terms of whether characteristics of the food environment impact dietary outcomes. And there's a lot of heterogeneity in terms of the food environment as well, but we wanted to know about heterogeneity in terms of how outcomes were measured. So you can see here, There's studies that were focusing on fruits and vegetables, sugary beverages, fast food, and diet quality. And most of these dots showing how they measured intake are over towards this side, showing that there was a reliance on more brief instruments. And what we did actually is went through the findings of each of these, and if the authors didn't declare their hypothesis, we tried to determine what their a priori hypotheses would be. So a new supermarket opening in the neighborhood, we assumed that they thought that would improve fruit and vegetable consumption. And then we looked at whether their hypothesis and their results actually matched. And we clustered together studies that use recalls, diaries or records, and FFQs, and then studies that use screeners or 1 to 2 items. Kind of wanted to put FFQs over here, but at least the FFQs are more comprehensive. And what we found is that 3 and 4 of the studies that use more comprehensive dietary measures had effects in the expected direction, whereas only about half of those that use brief instruments. So this doesn't necessarily prove anything, but suggests that the comprehensiveness with which we measure our outcomes is important in terms of us advancing the science. And also, back to this idea, and perhaps pulling FFQs out of that, if we were focused on recalls and records, again, these are culturally neutral and allows us to compare much more easily across studies. So all that to say that it's important to think about the measurement error in our data and to mitigate or correct it to the extent that we can. So we have these recommendations. We're starting to see shifts in research in terms of people using short-term measures more often. But what else can we do, and where else is the field going as far as improving dietary assessment? So again, although George Beaton didn't necessarily think that the future was an improvement of methods themselves, we again have seen quite a lot of technological innovation in recent years. This includes leveraging technology to reduce researcher and respondent burden. Some of this has happened quite directly as a result of some of those validation biomarker studies. So studies showing that recalls and records, or at least we think this applies to records as well, could collect less biased data, led to this recognition that if we're going to make that happen, we have to make it easier for researchers to collect recalls. And so one tool that's been developed by the U.S. National Cancer Institute is ASA-24, or the Automated Self-Administered 24-Hour Dietary Assessment Tool. And this can be used, it's freely accessible to researchers, and can be used to collect recalls and records in any size sample. So it's been used now in the U.S. I think it's upwards of 5,000 studies now to collect hundreds of thousands of recalls and records. And so this is funded by the National Institutes of Health, and it's cost several $1 million now, but if you think about the money that we're giving to researchers to go out and do maybe interviewer-administered recalls or develop their own tools, as opposed to creating and evaluating one standardized tool, really there's a lot of return on investment there. And so the National Cancer Institute, National Institutes of Health continue to support this. So we have done validation work on this where we compared self-report using the online tool to interviewer-administered recalls, and then also to observation. So we observed what people ate and drank for 3 eating occasions, and then compared that to their recall the following day. We found that people are able to report about 4 in 5 of the items that they actually consumed, and there's really not much difference between online self-administered recalls and interviewer-administered recalls. 4 and 5 might not sound that great, but actually when we look at the things that are being omitted, it tends to be items that are consumed in small amounts. So we, for example, served salad that had cucumbers and tomatoes. People didn't report the cucumbers and tomatoes. They may, it's not to say that some people didn't omit important main sources, but at a population level, what people are forgetting about is the small things. They didn't prepare these foods themselves. They didn't necessarily know there was mustard on the sandwich. It was those kinds of things. And in other studies we've done with other age groups, we've found the same thing, where it's mostly like condiments and additions that are being forgotten. We actually didn't find that there was systematic underreporting of less healthy things. We gave brownies and cookies and chips plus apples and bananas, and we really didn't see differences in terms of the reporting of those things. Our estimates actually of energy based on recalls were really pretty close to observation. And so I still stand by what I said earlier based on the biomarker studies that we should not be drawing upon self-report data to at least as our sole source of information on energy intake, again, because we can track anthropometrics. But it does provide refutation to some people who have suggested that we really can't rely on self-report data at all. We've also looked at the digital images. So this is an example of the portion size reporting. And so people can scroll through different sizes to get the one that's closest to what they actually had. And it does appear that having digital images that are tailored to the food helps people report more accurately. This is just one example. There's many other online tools that have been developed. For example, in the UK, there's Intake 24 and My Food 24. And ASA 24 has actually been adapted for Canada and Australia. And so one study that I'm involved in, we're now using these online interfaces in 4 different countries to collect comparable data and then also look at policy changes that, so for example, Canada has some calorie labeling that's now in place, or like the US has their whole food assistance programs that we don't have. We can do some comparisons, natural policy experiments based on the collection of these comparable data. And this would be really hard to do with a food frequency questionnaire that needs to be tailored to each population. So there's lots of other emerging developments in technology. This one at the top is called TADA. It's a mobile food record that's been developed by Carol Boucher and colleagues. And so this is targeted particularly to adolescents. They take a picture of their foods and beverages before and after consumption. And this little checkerboard is a fiducial marker. And that's used to try to automate recognition of what these foods and beverages are and how much there is. So, and then using the before after to actually come up with the amount that was consumed. So these groups are working really closely with engineers. They're using machine learning to try to teach the software to recognize different kinds of foods. And so while that's not ready for use necessarily at the moment, it's definitely coming. And right now, people are using mobile food records and having dietitians be the machine, actually, and figure out what was consumed and how much. This is hyperspectral imaging. So this is another really cool kind of technology. Someone at my university works in this area, and they're doing some really neat things with it where, again, it uses machine learning. This is an iPhone or other kind of smartphone with this little device on it, and it can take an image of food, it can take an image of skin, but for food, again, they're using machine learning to try to teach software associated with this to recognize different kinds of foods. You can think about, like, in a low middle income setting, that something like this could be really useful. In terms of skin, this is kind of sounds science fiction-y to me, but they can actually scan skin and figure out what kind of anemia people might have. So again, if you think about using something like that in low middle income context, it really could change the game. Also want to come back to databases. So in addition to improving tools, we need to continuously be improving the databases that underlie them. So one example in the US is a partnership between government and industry where they're trying to bring in more branded information. I don't know about Norway, but in Canada, our food composition information is pretty limited. We mostly rely on the US, and then we make some changes based on our fortification policies, but we have no brand information. And so it's like cookies, there's chocolate cookies, there's vanilla cookies, but you're not able to break it down by all the different varieties that are actually available in the market. So in the US, they are working towards that. Hopefully that will have ripple effects for us. So again, we can improve our methods, but we need to also keep improving on other fronts as well. So advancing biomarkers, I'm not going to say too much because we're going to hear more about biomarkers just after this, but we've talked about the uses of recovery biomarkers and how useful they are for validation studies, we can also make use of predictive biomarkers that help us. They're somewhat like recovery biomarkers and help us predict how much intake people might have had. These have been recognized for sugars, for example, maybe whole grains, and then also concentration biomarkers, which are things like serum carotenoids. And these can be used to better understand measurement error, so predictive biomarkers for sugars could be used in a validation study. And also, we can use biomarker data and self-report data together to help us better understand diet and health relationships. The metabolome, I don't know exactly where that's going to go. I don't know if you're going to talk about that at all today, but there's lots of development going on there. I think it remains to be seen how it's going to impact dietary assessment. So learning more about error and misreporting, again, validation studies continue. As I mentioned, we're working on one right now, looking at food records. Advancing biomarkers helps us with this because it allows us to learn about more dietary components. And once we learn more about error and misreporting, we can then improve our methods. So if we know what's leading, for example, like social desirability, understanding more about that might enable us to try to figure out ways that we can probe about foods and beverages in a more neutral way. And social desirability is something I think we kind of all assume it's an important thing, but there's not actually that much empirical data. And so including a measure of social desirability in your studies that include diet assessment might enable us to start to uncover what those links are. This is an example. This just goes back to the validation study I mentioned of ongoing pooling. So this is an example where collaboration is really important. Thinking about people around the world who might have access to these kinds of data. They might be small samples, but when you start to put them together with other samples, we can learn a lot from them. Improving our analytic methods, again, going back to Beaton. So the more we know about error, the better our analytic methods can be. And this, again, can incorporate biomarkers. So this is an example, thank you, going back to sodium and how difficult it is to estimate sodium intake. Perhaps we actually can calibrate sodium intakes based on self-report using biomarkers to get closer to what the true relationships are between sodium and disease outcomes. Embracing complexity is another important direction that the field is taking. So I mentioned previously the importance of multidimensionality and dynamism, how that makes diet complex. In the meantime, though, we've been trying to understand things like I gave the example of fat and breast cancer. Well, fat's not consumed in isolation, right? The proportion of energy from fat is only one part of a much more complex diet. And so the dietary guidelines for Americans have recognized this and tried to push researchers to think about diet in all of their complexity. The recent World Cancer Research Foundation report on diet and cancer also talked a lot about the need for researchers to go beyond reductionist approaches. This is a lot easier said than done, I think. So when you think about trying to capture dietary patterns, we might have an index like the Healthy Eating Index where we're taking into account different dietary components, but then we smoosh it all down into one number. So trying to think about how we can learn from different fields and try to look at factors that may decrease risk and increase risk in combination, as well as across the life cycle, so thinking about time-varying models. And also, this is a really neat idea I heard from Larry Kushi from California. It's the idea of linking cohorts that have used comparable methods in order to try to track diet and disease across the entire life cycle. And this is a blueprint for dietary patterns research from my colleague Jill Reedy at the National Cancer Institute, thinking about how we have to pull in all types of research, so surveillance and clinical assessment, intervention and policy research, and EPI, in order to understand the drivers, patterns, and consequences related to diet patterns. Okay, so closing the gap between research and practice, we talked already about matching measures to questions, and also reporting comprehensively the methods that we've used and what the implications are for reporting error. And it's amazing how often you can go to a paper, like if you're doing a systematic review, for example, and you try to figure out what dietary assessment method was used, and it's actually not specified, or you're not told which database was used, or it's details of that nature. So this is the strengthening the reporting of observational studies in nutrition extension, and more journals that publish nutrition research are requiring that this be included. Again, this lends to synthesizing across studies because you can better understand the implications. So to summarize, assessing dietary intake is very challenging. I've heard from a number of colleagues things like, I actually didn't work in dietary assessment until after I got tenure because it's too difficult of a field. It's hard to get funding, but it's also fun, and there's a lot of exciting work happening. We can't expect self-report measures to capture intake without error, but if we do a better job of linking our measures to our research question, I think that will help us to move forward. And as I mentioned before, collaboration is key to further advancing the field. So I'll just show this one last thing. I don't know if this translates, but don't throw the baby out with the bathwater. So there have been some debates in the literature and some criticism of the level of error in dietary data, but at the same time, we've done a lot of work to try to understand and overcome that error. I think we need to recognize that and build on that. Thank you very much.
So, thank you, Sharon. We will allow for 1 or 2 questions before the next talk, and then there will be 10 or 15 minutes of questions to both speakers after. So, if there's any questions immediately. So, yeah, I'll ask one.
Okay.
Yeah, you touched on it at the end, but what do you say to these people who are saying that dietary intake data is so unreliable that you cannot trust the results, that you shouldn't use it?
Yeah, so I don't know about any of you, but I repeatedly get emails after I publish in this area with actually CC'd to the journal suggesting that the article be corrected or retracted. And that's by one very vocal critic who I won't exactly name. So, I mean, the one issue is that the study that actually started off kind of this firestorm a few years ago, the analysis is actually wrong. They used the wrong cutoff. So they looked at NHANES data and tried to estimate the extent of energy underreporting, they called it, so misestimation of energy intake. And they used a Goldberg cutoff that the Goldberg creators actually suggested many years ago not be used. And if they had used the correct cutoff, actually the results look very similar to what I showed you from the Validation Studies Pooling Project. And so I think it, again, goes back to being honest about what our limitations are. We know energy is problematic. We know sodium is problematic. So what can we do to try to improve those? But we also know that we can learn a lot from dietary intake data. So if you think about what you know about the populations that you work with, much of it comes from self-report. And one of my favorite things is when people get up and bash self-report data, and then the very next thing they do is show a slide with like, here's fruit and vegetable intake among my sample, and I'm always like, where'd that data come from? So I think we need it, but we need to try to keep improving on it.